this is Jacqueline from Lichen Sclerosus Support Network, where our mission is to empower people with lichen sclerosus by providing evidence-based education and support so that we can live in a world where those affected by lichen sclerosus are informed, educated, and get diagnosed early. If you find the information in our videos helpful, please consider donating your time or money so that we can continue our LS education and support efforts. All right, so for today's video, we are here with Dr. Sanaee, who is a urogynecologist from Edmonton, Alberta. And we are going to be talking all about the lysis of clitoral adhesions procedure, both in office and in the operating room. We're also going to have a special section for folks who are located in Canada. So hyped for this video. I hope you enjoy. For those who are not familiar with Dr. Sanaee, she is a urogynecologist and chronic pelvic pain specialist at the Lois Hole Hospital for Women at the Royal Alexandra Hospital in Edmonton, Alberta. She's also an associate professor with the Department of Obstetrics and Gynecology at the University of Alberta. Dr. Sanaee served as the president of the Canadian Society for Pelvic Medicine from 2022 to 2023 and advocates for the standardization of urogynecology training and practice. She currently serves as the clerkship director for the OB-GYN course for third-year medical students at University of Alberta and conducts and supervises research trainees in the areas of urogynecology, pelvic pain, rural health, and medical education. In 2023, she was named one of Edmonton's top 40 under 40. As always, if you like our content, please give us a like, please subscribe, and with that, let's jump into things. All right, everyone, welcome to another LSSN video. We are here with Dr. Sanaee today, and I'm really excited for a number of reasons, but for one thing, and I'm pretty sure I'm not mistaken, but I don't think we've ever had a Canadian clinician on our channel before. And as a fellow Canadian, that makes me super excited. So welcome to our channel. Today, yeah, of course. And today we're going to be talking about clitoral adhesions and the lysis of procedure. But before we jump into that, I'd love if you could just introduce yourself to our audience, what you do, how you kind of got into the vulvar health space, because it's a pretty niche space. And I always say, I doubt when you were a little girl that you were like, I'm gonna do vulvas for a living, right? So how'd you get here?
Well, that's a very good point, because I did not think that. I'm a urogynecologist, which is a cross between a urologist and a gynecologist. I went through that route through the OBGYN route of training. And in urogynecology, vulvar health is sort of like a part of it, but it's not the main focus. So I mostly do pelvic reconstructive surgeries. Pelvic pain is another aspect. And then it sort of became obvious that a lot of our patients had vulvar pain too. So that's sort of how I got involved. And then, of course, lichen sclerosus would be one of the top reasons why a patient would have vulvar pain. So it sort of just became that way based on what my patients needed and what I was seeing.
Yeah, that's fair. I do think there's an incredible demand for vulvar health in general, and so many people that are suffering with different facets of vulvar, conditions. But there's also the question of where do I even go for that? But I definitely think there's a huge demand for it. So hopefully we see a lot more academics and clinicians getting more interested in the world of vulvar space, because we can't just have a handful of doctors for, a whole country, right? So it doesn't work very well.
No, and we're trying to make medical students and those training learn that, yes, it's the vulva, but you wouldn't be shy to examine the elbow. So we just have to be very pragmatic, and we're doctors. We should still be examining every part of the patient that is hurt and needs help. So that's something that we're trying to break down the barriers for. But you're right, there are very few of us.
Yeah, well, amen. And thank you for what you do. Very grateful, because again, the need is huge. So let's start kind of like right at the basics. What does it mean when I say clitoral adhesions or clitoral scarring or phimosis? What does that mean? Because that's really heavy jargony terms. And before my LS diagnosis, if someone said that, I would have a big question mark over my head.
Totally. And, me going through medical school, residency, fellowship, even though I did a fellowship in sexual medicine and vulvar health, I never even heard of these terms. The clitoris was just something we didn't talk about. But these terms, actually just this month, there was a publication explaining the difference between these terms because we use them all interchangeably in the science. It's not really clear what they really mean. And so how, if in the scientific community, we don't even know what they mean, how are we explaining it to the greater public? So this is all very new that we're becoming more rigid with our definitions and understanding what we're talking about so we can all get on the same page. So from what I understand, at least now, our definition of clitoral adhesion is any tethering of the clitoral hood to that glans of the clitoris. And phimosis is more of a action word. So it's not being able to retract the hood off of the clitoral glands. So they're both terms that we can use, and often we use them interchangeably, but that would be the difference. If there's a physical tethering, we're going to say adhesions. And then if it actually won't move and there's that rigidity, we'll say that there's phimosis.
Mm-hmm. So, because I know a lot of people are visual learners, got my vulva puppet. So I would say navy blue, clitoral hood, this little pink ball, clitoral glands.
Great.
We're going to work with a pillow puppet because it's YouTube and we don't want to get censored. So I just want to make sure I understand correctly. So adhesions would be maybe if, say, the hood is kind of stuck to the glands around here a little bit, or around here a little bit. And then phimosis would basically be when this clitoral hood is completely scarred over this clitoris. And so the retraction movement is when you kind of want to pull it up. So if there were no adhesions and there's no phimosis, if I were to retract, I would reveal the glans clitoris like this with ease. And this would be quite mobile and easy to move. If there is phimosis, what would happen is I go to retract, but there's no visualization of that glans. Is that kind of correct?
Yes, perfect. But there is also a spectrum. So you could still see the glans a little bit,
right?
But there's phimosis because even though you can see some of it, when you pull back, can't move it. Or you might see almost all of it, but you still can't move it. That's also not normal. So it's the motion and the adhesions both together that would say, okay, something's not quite healthy here.
Right. Okay, perfect. And then how do adhesions and phimosis occur in people with lichen sclerosus? Like what's causing it? Is it the inflammation? Is it what's going on there? Like why does this happen to many, but not all, people with vulvar lichen sclerosus?
Right. Yeah, it probably is the inflammation cycle. So there's going to be ebbs and flows of the times where the skin is very inflamed, and whether it's scratch itch that starts making it worse or just the inflammation itself. But then when it comes time to heal, unfortunately, the body can't tell, like, this is the right side, this is the left side, and I better heal to myself. It will heal crossed over and start to fuse in the midline. And that's when that coverage will happen. And we do see patients, I've seen many patients in their 80s and 90s, their whole life, where they have not touched, not looked, and the fusion is not just over the clitoris, it's over the vagina, urethra. And so that it might come to us and say, yeah, I can't insert anything anymore, and I can only pee like a dribble. But that's because the two labia minora, not just the hood up top, but everything has fused. And that's exactly it. I'm sure it's a combination of inflammation, and then the healing could be the hormonal changes. So there is multifactorial reasons for sure.
Yeah, absolutely. And then for folks with adhesions and phimosis, are they all, is that always symptomatic, or is it possible for some folks to have, you know, adhesions or phimosis and not have any symptoms, and, like, to your point, maybe not even know that they have this?
Totally. Now that I'm looking for it everywhere, and oh my God, so many patients have it. So some patients I might be seeing for a completely different reason. Say their prolapse, like vaginal prolapse, is bothering them, and we're planning a surgery, and I'm examining them, and then I'm like, wow, you have very dense adhesions over the clitoris. Does this bother you? You say, no, like these could be the symptoms. And then they say, no, I don't care. Do you want me to open it? No. So I'm like, great. If it doesn't bother you, it doesn't bother me. No problem.
Yeah.
But then you have patients who definitely can have very severe symptoms, and then the phimosis or the adhesions actually don't look that severe. Like they actually would look a little bit minor, but the symptoms are very, very bothersome. So I'd say you can see it both ways.
Yeah, absolutely. And that's something that I say a lot because I think when people get a vulvar lichen sclerosus diagnosis, a natural thing is to kind of go online, right? Whether it's Google or support groups, because they don't get much information from their doctor. So they go home thinking, what did I just get diagnosed with?
Yeah.
And in there, they learn for the first time that it can cause adhesions and phimosis. And for a lot of people, that's really scary to hear. And a lot of folks in that fear think that if you have adhesions or phimosis, you are necessarily going to lose all sensation. And one, that's not true. And two, to your point, like the degree of the adhesions or the phimosis doesn't always lead to the severity of symptoms. Like
Exactly.
some people can have complete phimosis
Mhm.
and they will tell you, I have great orgasms, I have sensation, I don't have any pain or tuggy or tightness. I don't have anything.
Mhm.
And to your point, a lot of these folks will say like, well, I don't mind. I mean, doesn't cause me
Yeah.
any issues. So, there's that. And then you have some folks that have really mild adhesions, but they will report a lot of pain or a big change in their sensation. And so that's one thing I always tell people is like, one, just because you got your diagnosis doesn't mean that you will get adhesions or phimosis, especially with early treatment and intervention. But
Mhm.
two, if it does happen, it doesn't necessarily mean that you're going to lose all sensation. And then C, just go through the whole alphabet. If
Yep.
you do have symptoms, there are
Yeah.
things that can be done, and we'll talk about that in a little bit. Other than pain and kind of loss of sensation, muted orgasms, are there other symptoms that people kind of report with adhesions?
I'd say those are the two big categories, and within
Yeah,
there could be nuances. Like if
right.
it's pain, could it be like you said? Could it be this tugging sensation? Could it
Mhm.
be that grain of sand
Yeah.
sensation, like in the eye? It's the same thing. The clitoris
Mhm.
is rich with nerves. If anything gets trapped under that phimosis, it's always irritating. So
Right.
that could be a different type of pain feeling. Um, some patients it will actually radiate. So even though the epicenter is the clitoris and
Mhm.
clitoridynia, as we would call it, it can become just general vulvar pain, but
Right.
it really is the clitoris that's being stimulated and irritated. So there's different ways pain might manifest. And then the sexual dysfunction, like you said, it could be, I have patients who'll say, I had great orgasms, no problem. Uh, clitoral sensations were fine, and
Mhm.
then slowly to the point now that I feel nothing, like I can't even feel any sexual sensations. Oh, and it's because there's that covering. Imagine now you have a thick layer of skin over
Yeah.
the clitoris, so you're not able to stimulate it the same way. So that could be the case. And some people, it's really quick, like it'll happen within the span of
Mhm.
even a year.
Right.
And again, it's because of what's been happening with that inflammation. So I'd say those are the two main, whether it's sexual, what we would
Mhm.
call dysfunction, or pain. Those are
Yeah.
the two big categories.
Right, that's typically what I hear too from people with adhesions or phimosis. And again, like pain is a broad category, so people will use different adjectives to describe
Mhm,
that pain, but it does come down to kind of painful sensations. One thing I want to kind of go back to is you were saying that
mhm.
you kind of see adhesions a lot more frequently now. And so I wanted to also highlight that adhesions can happen in folks without vulvar lichen sclerosus as well,
Yes,
correct? Right. So it's
definitely.
not only vulvar lichen sclerosus that leads to
Yeah.
adhesions. What else can cause adhesions?
I'd say the vulvar lichen sclerosus is number 1 or number 2, and the other one that's number 1 or number 2 is what we would call smegma or keratin pearls,
Mhm.
which is more like an inflammatory reaction or inflammatory state where it's debris or skin that kind of gets trapped under this hood of the clitoris. And just with retraction, slowly after patients have been doing this for a while, if they haven't been doing it for a while, this it's almost like tacky and
Mhm.
inflammatory, and so it will cause the same adhesions. But as soon as I'm, for example, doing the procedure where we
Yeah.
lyse these adhesions, you can tell, okay, is this person in the lichen sclerosus category? Is this more of a smegma keratin pearl? Because you can actually find little white dots when it's
Mhm.
keratin pearls. You can have both too,
Right.
but I would say those are the top two reasons. We see other patients with other vulvar conditions, whether it's lichen planus or more rare dermatology conditions.
Mm.
It could also be, we've talked a little bit, you and I, with
Yeah.
hormonal changes. So someone who starting the birth control pill and the skin response is different.
Yeah.
So there can be other reasons. And of course, there's female genital mutilation or cutting where surgically there's been a skin adherence over
Yeah.
the clitoris. So I'd say those are the handful of most common reasons, but VLS would be probably number one or number two.
Yeah, yeah, absolutely. And smegma, just to be clear, that is just dead skin cells and kind of like oils that our body naturally produces.
Yes, and I realized when I was talking about it, I was being hesitant, but that's because I never want the patient to feel like they're to blame, because that's the first thing they're like, oh no, I feel dirty,
Yes,
or like I did something wrong, like
right.
what have I done? That's gross. Like I don't want
Yes.
patients to feel that way at all. It's very
Hmm.
natural. It's our skin cells.
Yeah,
Um, like we teach little boys when they're young that they have to retract
absolutely.
back the skin, they have to clean, but we
Yeah.
never teach little girls that. So how
No,
could that be an expectation that that's normal to always be pulling back in the shower or just making sure everything's moving? So yes, it's just old dead skin cells, but when
yeah.
it just sits there, it can become inflammatory and irritating.
Absolutely. And I totally see where you're coming from, because I have seen it listed in medical journals as just like hygiene, which does kind of like put shame and blame onto
Yes,
the patient. And but to your
exactly.
point, we're not taught this.
No.
I don't know how many people in here watch TikTok, but that's how I go to bed sometimes when I can't sleep. I just scroll TikTok. And there was
Yeah.
this viral TikTok that went out
Yeah.
of this
Oh,
person. I don't know their age or whatever, but she was basically like, oh my God, no one ever taught me to pull it back. And holy crap, like there's stuff in there that you got to clean out. And then like this went viral because like
oh,
so
good.
many,
Okay.
yeah, and so many people are like, what? Like
Yeah.
that's a thing? Oh my God, I just went in the shower and did it. You gotta be kidding me. And like, so, but again, like we're not taught this. So like
No.
it's nobody's fault. And again, like smegma, and I love that word. It's just like it's such a fun word to say. But everybody has it. Like that's just the
Yeah.
body's naturally shed kind of like dead skin
Totally.
cells and oil. So it's nothing to be ashamed of. And so I totally appreciate that point, because yeah, whenever I see it listed as hygiene, I'm like,
Yeah.
well,
Exactly.
maybe
Yeah.
not the greatest way to kind of frame that, but yeah.
Yes. Yeah,
So,
and it's
and
a little bit.
go.
Sorry. I just wanted to mention, because we also throw so many creams and lotions and
Oh yeah.
potions at patients, and then that can also be what I find trapped. So it's
Mm,
this delicate balance of adding these oily substances sometimes, but
right.
also how do you make sure that you're sometimes cleaning enough that you have that starting from scratch and not letting any debris get trapped. That's all I wanted to
Yeah.
say.
And to your point, I'm like, it's such a delicate and tricky balance, because like
Exactly.
we know that like over cleaning the vulva is not
Yes.
great and can
No.
lead to contact dermatitis type reactions and a whole
Yeah.
slew of things. So we don't want to like go in there with like a loofah and like
No.
squeeze out some, I don't know what brands of body soap there are. I can't think of any right now, but you just squeeze that on and then you're scrubbing. Like we don't want to do that either. So it is really this delicate balance of, yes. And to your point, these lotions and potions, a lot of people with vulvar lichen sclerosus are at minimum going to have a topical corticosteroid
Yep.
in ointment or cream form. And then they're
Mhm.
probably going to use an emollient or a barrier cream like Aquaphor or something like that. So again, it's that balance of cleaning but not
Yeah.
over cleaning. Do you have any tips on that? Like, I know a lot of people will just say warm water in your fingers. Some people will say like a pH balanced vulvar soap. And should people be retracting a little bit and taking warm water to kind of clean the area? Do you have any tips on that?
I just say do the retraction every time you're in the shower, and
Mm-hmm.
that's enough, just so
Yeah.
that the motion is there. Because as long as there's
Right.
movement, whatever's in there will naturally come out. Like you don't need
Right.
to try to get in there with a finger or Q-tip. I don't
Okay.
do that too much, but
Right.
just so it's on your mind, a bit of retraction, hold it for 10 seconds,
Yeah.
just so that it's moving and not that rigid air skin that's never being moved.
Yeah.
That's all I
And
would
then
say.
like the warm water that's kind of like running
Yeah,
over that is enough. So
totally.
we don't need to use any like fancy products or
No.
vulvar soaps or
Anyway,
anything
we're
like
still
that.
learning. So maybe if we did this in a year, I'd be like, oh, there's new research. But at this
Right.
moment, I would say no. I do tell patients who are the adhesions are starting, or we've actually just taken them down,
Mhm.
we have a regimen with sitz bath. So you're actually
Okay.
deliberately sitting in the warm water with the Epsom
Right.
salts and doing the retraction. So that's a little different because you have it and you have the
Yeah,
condition. I mean, I guess everyone could do that, but I don't think that's necessary.
that's fair. Yeah. And again, we don't want to like over soak and like live in our bathroom either, right? We still want to
Exactly.
live
Yeah,
our lives.
totally.
One more question in terms of symptoms and adhesions.
Mhm,
So, when folks have a loss of sensation or they say that the quality of their orgasms have decreased,
mhm.
is this always due to adhesions, or can you sometimes have loss of clitoral sensation, but like there's no adhesions present?
I suppose it could happen, but
Hmm.
the vast majority of patients, as soon as they say that, I'm like, "Let's have a look at your clitoris."
Right,
It's just so common. But yes, it could happen,
right.
and then we're looking at other causes.
Right.
But that would be I would say it's definitely the number one reason.
Yeah. Okay. Totally fair. So let's talk about management with
Sure.
adhesions and phimosis. And for this, I want this to be a little bit more like conservative, i.e., like before we go down the surgical route, what are things that can be done if we currently have adhesions or are worried about developing adhesions in the context of the person has vulvar lichen sclerosis?
Great question. Um, Well, we say motion is lotion. So, like we talked about the retraction, the movement, keeping everything as mobile as possible, and the routine. Yep.
So just pull it up like
Yep.
this. And like,
Yep.
you don't have to stay here for ages, but just I'm
Yep.
guessing, a few times,
Yep.
get that motion in, get that blood
Yes.
flow, get things moving.
Yes. And with that puppet, we also. So I would say that not all pelvic physiotherapists are comfortable with this yet, and it's part of the
Mm,
training that we're launching across Canada. But a pelvic physiotherapist can be gold, and I know you've referenced
mm,
them many times
yeah.
before, but because physiotherapists train in scar mobilization, and this is, again, it's like any other scar. So the way to address it with pelvic physiotherapy, they also do bulbocavernosus massage and technique. So it's much lower than where the external clitoris is, but you're actually putting a finger in almost inside the vagina, not quite, but inside the
Like
vulva, and your
reach,
thumb is
like
on
through
the
that.
outside. Yeah. And you're kind of doing this massage kind of all the way up and down
Mm,
into the labia majora. So it brings blood flow and
yeah.
it just moves everything. And because the clitoral complex, like you just showed, is so much bigger than we can see, if you mobilize one part of it, you're helping the other parts because it's all
Oh,
connected.
that's so neat. Okay.
You can go vaginally and do that kind of massage where you're pulling down and massaging, like a pill rolling technique, we call it. So
Mhm,
kind of
yes. Yeah.
gripping the labia majora and going up and down and
Hmm.
massaging it. That will bring the blood flow to the clitoris, to the entire thing. So
Right.
those are the two, generally the retraction and then the bulbocavernosus massage. That are the two techniques that physiotherapy usually teaches you. And
Hmm.
there was a study almost over 10 years ago now, published in 2015 in a physio journal talking about treating clitoral phimosis. So
Oh,
just because
amazing.
the surgical side, we're just figuring it out now, but the physiotherapy side, they actually showed that by doing this retraction and techniques, I think it took a while, it was like 16 months until the phimosis was gone, until the
Right.
adhesions were gone, but it can be done with just manipulation and
Hmm.
these techniques and exercises.
Yeah, absolutely. I mean, that's what I ended up doing as somebody at the time that was living in Ontario. I couldn't really find anybody that was doing the surgical lysis of adhesion or even the
Mhm.
non-surgical version. And so I was basically like, all right, what else can I do? And came across, pelvic floor physiotherapy being a great option. And luckily, I had an incredible pelvic PT that, not only knew the technique, but actually
Mhm.
herself has lichen sclerosus.
Yeah.
And so I worked with her. And to your point, it is more of a long game
Yep.
type situation, right? It's not going to be you go into the pelvic physio's office, they do, some of that pill rolling and some of that myofascial work, and bam, you go home, no more adhesions. It is, because it's more conservative, because it's much more gentle, it is going to be a longer,
Yes.
time to wait, but it absolutely can be incredibly beneficial and get rid of some of those adhesions for people. And I think we'll get to the whole Canada thing in a bit, but that can be nice for folks who are living in countries where maybe there's not a lot of surgeons performing these procedures, or it's just not accessible to them from a financial perspective. Because I don't have the statistics on this, but I would be willing to put money that there are more pelvic floor physios than there are clinicians who perform the lysis of adhesion surgery in Canada.
You're probably right.
Yeah. Pelvic floor physios are pretty easy to find for the most part, depending on where you're situated. But they're definitely, I would say, a lot easier to find and a lot easier to get into. Because if you're waiting for
Yes.
a vulvar health specialist, that's
Yes.
the other time, at least in Canada and in certain European countries, you may have access to a vulvar health specialist, to somebody that can do the surgery, but then you're hit with 2, 3, 4-year wait times. Whereas the longest I've ever heard anyone wait for a pelvic floor PT was 5 months, I believe. And I don't think that's the norm.
I thought you were going to say weeks, but
yes, no, exactly. No, typically it's weeks. It's not really that long to wait. And so they definitely are a great resource. And I do just want to add that, when we're talking about prevention and what can we do kind of proactively, so we've got, keep it mobile. Maybe you make a habit of doing that in the shower at the same time. That's good practice, so that we can get rid of some of that buildup, anything trapped under the hood. But also treating your lichen sclerosus with,
Yes.
evidence-based medicine, such as topical corticosteroids, go a long way in preventing. Because with people, I know people that got diagnosed with vulvar lichen sclerosus, but they don't have any adhesions, and they never did. Their time from symptom onset to diagnosis was pretty short. They got on their, steroid or calcineurin inhibitor treatment, topical, and then they kept treating, and they never went on to develop it. And so not everybody does develop it, but again, we want to be proactive, and we do have good research showing, the benefits from like that proactive preventative side of things. So in addition to doing all of these techniques and potentially working with a pelvic floor physical therapist, we definitely want to be treating the lichen sclerosus according to your physician's instructions, of course.
Perfect. Exactly.
So let's talk about the actual lysis procedure. So what on earth does lysis even mean? And then walk us through the procedure in general, or as you do it. Is it in office, or do you go to an OR? Is it arduous? And by that, I mean, like, am I in the OR for 7 hours, or is it like 30 minutes in and out? And then what does recovery typically look like for that?
Great questions. You know what? Maybe we should call it something better, but we do call it lysis because in surgery, when we have adhesions in the pelvis, in the abdomen, anywhere else in your body, we call it lysis of adhesions. It just means separating scar tissue, but that's what we call it. So when I see a patient with adhesions and they have symptoms and they want to do something about it, I will offer them either we can do it as an in-office procedure or we can go to the operating room. That's generally speaking. Once in a while, I've come across patients where the adhesions are so dense that I know I need either a scalpel or electrosurgery, and we have to go to the operating room for that. But I'd say most patients, that's not the case. Most patients, it's going to be fine to do it as an in-office procedure. So I just did one the other day, and the patient wanted to do it right away because I'm a fan of the see and treat now. Like, instead of just seeing the patient like, yes, you have this, go away for a few months, come back. Like, let's just deal with it right now. It takes 10 minutes. Let's just do this.
Wow, 10 minutes.
Yeah. So we freeze the dorsal nerve of the clitoris. So the nerve has the clitoris has big nerves. So the dorsal nerves of the clitoris are just as big as your funny bone ulnar nerve. So we want to freeze that. And we do that with a needle. This is probably the worst part of it. So the freezing itself, we just go right under the pubic bone. So I don't want to go right into the clitoris. That's horrible. So we go from where the nerves start to come in. So it's very, very low abdomen, like pretty much as low as you can go. Needle, then you're frozen. And then once you're frozen, we just give stress balls to the patients to play with, or
Yeah.
our nurse is there with us as well if they want to be distracted, or some people just want to listen to music, whatever they want to do.
Mhm.
And then I just take 2 Q-tips and I literally just pull the adhesion apart.
Okay.
Sometimes that's all I need to do. Most of the time, I also need to get the Q-tip like onto each side to separate the glands
Yeah,
from
okay.
the clitoral hood. Once in a while, I will need to use an instrument, which is called a hemostat, and that is a metal instrument where we just kind of peel
Okay.
apart the
Yeah.
adhesions. But it always shocks me that the patient's just like do do do, like can't feel
Right.
anything. Like thank goodness this
Yeah, no
freezing really.
kidding.
So then like 10 minutes of me just pulling and making sure all the adhesions are broken down.
Right.
Then we'll put a little bit of freezing cream or ointment. Uh,
Okay.
we used to do it with just that before we did the freezing block, and
Mhm.
patients could tolerate that too. It wasn't as good as the block,
Yeah, I
but
wouldn't.
once I learned how to do the block, because again, this is
Yeah.
something that I didn't learn in my training, but once I learned that, that's much better.
Mm.
Um, the block lasts about 6 to 8 hours, so I tell patients, that night they can kind of take it easy, but the next day is when we have a little regimen of Epsom salt baths, sitz baths, lots of freezing jelly. If they have
Mhm.
lichen sclerosus, I may inject steroid right into the corona, so that the edge
Okay.
of the edge of the clitoral hood, to try to decrease as much inflammation, because
Mhm.
even within days, if your body is in that state of I need
Yeah.
to heal and I'm a super healer and inflammation will come, then I just want to decrease as much inflammation as possible. So I'll actually inject steroid right
Right.
into that clitoral hood junction. If not, to get right on your corticosteroid
Mhm.
topical. And then we've just started to get patients to see our physiotherapist within the first week. So ideally the first couple of days, but within that first week, and most of
Mhm.
them already have seen a physiotherapist before,
Right.
to again show them the retraction. And I will,
Mhm.
once we're done, most patients, I would say it's 50-50 actually, if they want to see with a mirror the before and after,
Mhm.
so that they can see the difference and be like, okay, so
Right.
this is as good as it gets. This is what it looks like when you can see the full extent of the glands on the outside, and this is how I retract. So we just go through that a little bit before they leave. They see the physiotherapist in a couple days. They keep doing the Epsom salts and this regimen of steroid, xylocaine, or whatever, freezing jelly, ointment,
Mhm.
until it's comfortable. Wearing tight pants, bicycle, that sort of stuff is kind of a no for the first week.
Yeah.
And then the studies show that up to a third of patients, the adhesions come back.
Mhm.
So that post lysis regimen, mobilization, exercises is
Yeah.
so important, and treating the lichen sclerosus is
Mhm.
so important to try to keep the adhesions from wanting to come back.
Yeah, absolutely. And I definitely did want to talk about recurrence rates because I think
Yes.
that's something that, some people are, when they're considering, do I do it, whether it's surgical, non-surgical, in office OR, is if I do it, is it just going to fuse back up in a few months? Because I don't want to do all of that if it's just
Yes.
going to, kind of
Totally.
fuse back. And we do know that with lichen sclerosus, it does, because of those high levels of inflammation, it does kind of want to stick back. And I always tell people that are considering the surgery that the biggest part of the success is actually post-procedure.
Mhm.
It's going to be the aftercare and following those instructions. And so to me, I always get a little apprehensive when someone says, oh, the surgery or the surgeon said there's no aftercare. Just put some Vaseline and go forward. That to me, usually I have a moment of pause and hesitancy because, then there's nothing being done to kind of prevent
Yeah.
recurrence. And so I always tell people, like, there's going to be some work on your side after, and that's going to really reduce the risk of kind of re-adhesing, refusing, if you will.
Exactly. And most patients, and this is what we want to study in more detail, but most patients, when they come back, I see them around the 6-week mark, are thrilled. Like the result, this is one of those procedures. We don't have too many of them in medicine, but the before and after is very good. So the symptom they wanted treated, whether it
Right.
was sexual muted orgasm, or whether it was a constant tethered pain, tugging, that is gone. And I've had a patient, I didn't mention this as the symptoms, but she had for 17 years persistent genital arousal
Oh,
disorder. So
yes, absolutely.
yes, because the tightness was
Makes
just
sense.
stimulating all the time. So again, with this one 10-minute procedure, she's like, it's gone after 17
Right.
years. So
Wow.
yes, leading up to it, of course, the symptoms are there. But like you say, I feel like the more you put into it after, the longer it will last, and hopefully forever. I've had patients who will come with vulvar lichen sclerosus and would like the procedure, but the skin is just in no shape to go for it. So we'll say
Yes.
we need 3 months at least of very diligent work with the corticosteroids, with the emollient. Like, we need this skin to be in much better shape. And thankfully, the patients are on board with that.
Yeah.
And I feel like if you're going into it in better, with better skin, if it's as good as it's ever going to get, if you're like, this is as good as it's ever been, then of course
Right.
we'll go ahead. But if we can get it better, then we probably will have better outcomes after.
That's a good point. Yes, I was thinking before we got on this recording, if I've ever heard a clinician that does the procedure say that they would do it on like active LS, all the clinicians will always say, we want the skin in clinical remission. We want the symptoms well managed. You need to get to that point before we do the surgical procedure. Are you able to explain to viewers maybe why that is the case, why it's not recommended to do on skin that, you know, has active LS where the symptoms are very, very intense still?
I would say the biggest reason is because of that recurrence rate, and because if the skin is that inflamed, it does make it more difficult for your surgeon in
Right.
general, because the tissues are fragile. The planes, we always look for that fusion line. The planes are actively inflamed, so you actually can't see. So the risk, I would say, of injuring the clitoris would be higher, because you might be in the wrong spot. And when you're trying to tease out the adhesions, if there's active disease, you might be in the wrong area. So it's safer not to do it, but it's also for afterwards. If there's more inflammation, the body will just want to heal again.
Yeah.
So you've kind of gone through it all. I don't want to say for nothing, but
Yeah.
not getting the results you were hoping for. But we have that as a general principle of all surgery. Say someone has delivers a baby and they had a tear and it's infected, and the stitches fall apart. A lot of patients will go, I want that fixed again. But when there's
Yeah.
active infection is just another type of inflammation.
Right.
It's the wrong time to be putting stitches in or
Makes
redoing a
sense.
surgery. So same principle. The more calm, quiet, in remission the tissues are, the better everything will go whenever you're looking at any type of surgery or procedure.
Yeah, absolutely. That makes a lot of sense. Now, aside from recurrence, are there any risks to getting this procedure done, whether it's in office or in the operating room?
There's always risks to any procedure, that's
Exactly.
for sure. So we range from the anesthetic risk, which isn't very minimal, but it's still there. If you've never had freezing before, could you have a reaction? So we have to talk about all of that.
Right.
I would say, though, when it comes to damage of the clitoris, like worsening of sexual function, like these are things that I'm very afraid of,
Yes.
and
Yeah.
I kind of
Yeah. And I
struggled
think the
with.
patients too.
This is what started me on this whole vulvar thing, is realizing that I never learned the anatomy of the clitoris as a
Yeah.
doctor in medical school. What business do I have operating on this area? So really learning the anatomy and understanding what could go wrong. But thankfully, because of how distal it is, and the principle that I follow is restore normal anatomy. So we're not trying to overdo anything. We're trying to use non-surgical techniques as much as possible. So just the separating. So even though it's possible, and I tell patients it is possible, we make your symptoms worse. Thankfully, I haven't seen that yet. And I think, unfortunately, with the literature, we just don't really know what that would be.
Right.
So could it be, oh, I should say some patients it's the opposite, where suddenly they're like, I feel too much. I feel everything. It's like the wind is
Oh,
now
right.
blowing this,
Yes.
and it's like too much. So, and they don't like that. I've had a few patients, so I have to warn, patients about that. So I just say use more freezing. Let's numb it if it's just hypersensitive now, because now the glands, your little pink ball there, might touch the underwear. Maybe it's more exposed. It might be more sensitive. So I would say those are the more common, but thankfully it's not a high risk procedure. We're not cutting into any areas. We're just trying to bring things back to the way they were.
And I just want to clarify, you did say that the injection to numb, you're not injecting into the clitoris itself, right? So there's no needle going in here.
No, it's from higher. I should have had my pelvic model now that I think about it. It's the mons, which is the upper area of the vulva, or you can think of it as low on the abdomen as you can go, right
like
where
kind
the
of that
triangle.
If you were standing straight up in the mirror, that part.
Exactly. Yep. So I just feel where the bone is and just go right in front of it, and I know I'll catch those two dorsal nerves of the clitoris on their way to the clitoris.
Well, that sounds way better. I always was like, oof, I don't know if I want a needle to the clitoris. That sounds...
I think some people do it that way, but I also would not want that. So I
love this way. This way sounds way more gentle and way more easier.
I learned this because actually I found out that that's how they numb the penis for little babies when they do circumcisions, or if they have bad phimosis. That's what they do. They block the dorsal penile nerves. As a gynecologist, I don't know anything about that, but when I learned that's what they do, I was like, we can do the same thing for women.
Yeah. That's amazing. And I mean, like if we can avoid injecting directly into the clitoris, like if that was our only choice, then okay, fair. But like there's a clear option that seems way more patient friendly than an injection into the clitoris, which still, like, even just each time I say it, I'm like, oh my God. That feels, I can feel the pain.
Can you get permanent damage from freezing? Like, these are some of the risks like I think about and patients will think about. But we freeze like any part of the body that needs stitches, needs anything. So it's that balance. Like, we don't want to hurt women while we're learning about these procedures, but we also don't want to deny them care or pain relief or fear that something bad might happen. So thankfully, I've been upfront with my patients. This is a newer procedure. We're learning this. Would you like this? And so far, I've probably done the procedure. I've kept a bit of a log, just almost 100 patients. And I'd say of all of them, majority will go for the block, and it's worked well.
Amazing. That's really great to hear. So, as I said at the beginning of the video, you are Canadian. So I want to talk a little bit about the situation of clitoral adhesions and, the surgical procedures in Canada, because we've had, Dr. Jill Krapp and Dr. Rachel Rubin from the United States come on our channel before and talk about the procedures. And I think a lot of folks that follow Lichen Sclerosus Support Network and myself, they know of the doctors in the United States that do this, but what about those people that don't live in the United States? Now, certainly, you absolutely could see these doctors by buying a plane ticket, hotel, all of this, but that's an exceptional amount of money. You still have to pay for that procedure out of pocket. You have to do the conversion Canadian to USD, which is quite hefty. And so that's going to be inaccessible for many folks in Canada. So what is the landscape in Canada? What do we know? What do we not know in Canada in terms of who does the procedure? What kind of doctor? Are there people other than yourself that do it? What does it kind of look like right now? Or do we even know?
Well, first of all, I should give kudos to both of those doctors you mentioned, Dr. Rubin and Dr. Krapp, because it was their studies that made me realize I need to learn this. And I went to the ISWISH conference a couple of years back and actually hounded them both down and said, teach me. So that I could at least do it in Alberta. The landscape in Canada, unfortunately, we work in silos. So I know what happens in my world, in urogynecology, and how we're training people. Is there a parallel in vulvar dermatology? Is there a parallel maybe happening in urology, like Dr. Rubin's a urologist?
Yeah.
Maybe, but I have not been able to find them. And so unfortunately, so much of it falls to patients to navigate. And I know, Jacqueline, you've been a huge part of that and helping patients find care where they need to find it and hopefully closer to home. But I can't even tell you the names necessarily of people who are doing this procedure. I just think it is picking up. And so it is on the radar of at least the Canadian Society for Pelvic Medicine. That's where we're doing workshops to train fellow urogynecologists to do the procedure. So I think that the word is getting out and it is happening and we're training, but I can't say there's an obvious network that I can refer patients to right now.
Yeah, to your point, like if someone tells me, oh, I live in X state in the US, I'm looking for a surgeon to do this, I can give names, like actual names, their full
Okay.
name. In
Wow.
Canada, that's pretty tough. I just learned of a physician that does the procedure at Sanaee in Quebec. It is a private clinic, meaning that you would pay out of pocket, meaning because Quebec has some weird medical loopholes. If you're from a different province, you could fly to Quebec and get it, which would be substantially cheaper than going to the United States, and you would still pay within, because otherwise Canada has a bit of a challenge, because I, as somebody, right now in Quebec, I can't go fly to Alberta and see you to get the procedure. I would need to be an Albertan. And if someone does the procedure in Ontario, but they live in Nova Scotia, they would, and there are some loopholes about, I believe, where if your province doesn't do a medical procedure, you can apply. And then basically the two provinces will essentially argue over who's going to cover the cost. But say you're in Nova Scotia and there's nobody in Nova Scotia doing the vulvar lysis of adhesions, you could apply and be like, okay, well, I want to go to Alberta. I need this procedure. Nobody does it here, so on and so forth. But it is, again, a long and arduous process. And I think ideally it would be lovely if there was at least one clinician in each province that could do it. Then, of course, we still want to train more, because one per province, wait times are going to be exponential, because adhesions are common both in people with VLS and not. So I suspect that if we start kind of talking about this more and we get, kind of one doctor in each province, that's great. But again, I think the wait times are going to be very, very long and complicated. And I know that we've had many discussions about this, but I often have to tell people at a certain point, you need to get on a plane. You got to go to the United States. And that's something that, I really want to change. I want people to be able to access these types of, procedures in their own respective province or in their own respective country. Because again, I know people that fly from Europe to go to the United States to get these procedures. And I'm just like, that is so much money. And, it's wild to me that people are going to have to pay so much money. And it also does put so many people in a position where they just can't do anything. Because again, that's not accessible to most people. Or they're going to have to start, GoFundMes just so that they can get to the States and get their healthcare. So it is great that the Canadian Society for Pelvic Medicine is starting to do these trainings. So if there are any healthcare providers that are watching, or if you just want to let your healthcare provider know about these trainings, that's also another avenue, right? Like sometimes we as patients can be like, hey, when I learn about new CME courses or trainings, I let my healthcare providers know, like, take this, your team should take this. It's a really great course, right? Because that's how, word can spread.
Yes, that's how it works.
Yeah. And I think like another thing that you and I have been speaking about in Canada is we just don't know what's going on. We don't really know much about the landscape because there haven't really been any studies or surveys kind of disseminated to capture this type of data. So I can speak from my lived experience, in Quebec as someone doing patient advocacy work in Canada and globally. And you can speak to your lived experience, but we don't really know if that's going to map on perfectly to all of Canada and what that looks like. So maybe you can tell us a little bit about the surveys that your team is working on and what we hope to achieve with that.
Absolutely. So we're hoping to answer the questions that we're talking about right now. So everything we're saying, well, we don't know. We don't know who's doing these procedures. We don't know who has the capacity and can learn them. And we don't know the need. Like, how many patients are we talking? So our survey that we want to disseminate, and hopefully you all out there will do this survey, there's a healthcare provider version and there's a patient version. And we're asking for your perspectives from what you've seen and what you know. So we're asking healthcare providers, do you even know that this can happen? Are you aware of this diagnosis? Do you know what this condition is? Would you know how to confirm the diagnosis on examination of your patient, so that we know how much is being taught, how much, what kind of gap there is. And as a medical educator, that is good feedback for me and for the rest of our gynecology-based teaching that we do across the country. And then the other part is asking the patients, how long do you think you've had this for? How have you asked for help? What was the response when you asked for help? Did your healthcare provider know what it was or who to send you to? Have you found someone? Maybe you know someone. Maybe you know someone who's doing tons of these procedures and we don't know. So that's the basis of this dual survey, so we can get perspectives from both sides. And hopefully that'll help, once we publish that information, help all of you find a provider in your home province. And if not, it empowers us to go to ministries, to go to the province and say, this is a need. And if we can't, then we say, look, people have to do this cross-country travel. How do we make that work? How do we make it feasible and accessible and affordable?
Yeah, absolutely. I'm really excited, and I'll let folks know a little bit more information. But I just want to speak again on to how important capturing this data is, because if we want to advocate for change, we can't just go in and say, we see that, we feel that, we think that, or I spoke to someone and they had this experience, right?
Mm-hmm.
When it comes to advocating at deep policy levels in healthcare, we need numbers, we need data.
Yes.
So we can't make the change, because man, we sit together often and, like, we'll be like, we need to change this, we need to do this. Like, I mean, the amount of studies and ideas that we have could probably keep us busy until we leave this planet. But we can't do a lot of this, and we can't start working to enact the change that we want to see, and that I know a lot of fellow Canadians and other people want to see, until we get that data. So yes. As you mentioned, there's going to be two versions, a healthcare provider version and a patient version. We're working on finalizing those surveys, but when they are ready, both Lichen Sclerosus Support Network and myself at the Lost Labia Chronicles, we will let you know. So we encourage you to sign up to our respective newsletters and social media. We will disseminate those surveys on both platforms. And I will have our social media links and our subscribe links in our kind of description notes below, so you can always get on there. And then for our Instagram or social media, if you will, that is at the Lost Labia Chronicles for myself and at Alice Support Network for LSSN. So you can definitely check both of those out. We will let you know when they are ready to take. And again, hopefully we'll get a good turnout and we'll get some data so that we can start making some changes for the good. Before we kind of close out, is there anything that you would want to say to patients that, might be scared hearing about adhesions, or, they're considering surgery, but they're really worried about it? Anything you want to say to those types of people?
I want to say that as a healthcare community, I'm sorry that we've been not able to support you and meet you where you're at, and that your needs are valid, and we are working on it, and we will get there. Please know that you can always turn to Jacqueline's channels and learn the latest and greatest, because she's so up to date and will be able to guide you with what we know. Keep doing what you're doing. Like, you have all the information, you are empowered, you know how to treat this lichen sclerosus. So although it gets arduous and you sometimes just don't want to have this, so you stop the treatment and pretend. I'm like that. Sometimes I just want to pretend it's not there. And but that is probably when we get into these situations where phimosis and adhesions can occur. So it is a lifelong commitment, but just keep up with it, and we're here if you need us. That's my message. But I also want to say, Jacqueline, I noticed your t-shirt and I think you should show it off. That's from one of the workshops we did to teach healthcare providers how to do this procedure. So it is coming to a province near you, but we just need your help to figure out where the needs are and how we can best address them.
Yeah, I definitely went full clitoris mode from the workshop shirt. I got like this clitoris, this. I got my vulva with the
you're
other
set.
part of the like. I'm just decked
Just
out in vulvas and clitorises right now, representing very hard.
So good. Very
Was
prepared.
there anything on this topic that you wanted to say but didn't get a chance to say before we close out?
No, I think that we talked about everything, but I just again want to highlight the pelvic physiotherapist.
Yeah.
Like Jacqueline said, they're everywhere and they know how to deal with scar. And that's really at the end of the day what this is. So start there if you don't know where to start.
Absolutely. And pelvic floor physiotherapists are very well trained through a trauma-informed lens. They also have about a full hour with most of the time, sometimes it's 50 minutes, but they have a long time with you. So they can really move through this gently and quickly. It's not a 5-minute with your GP kind of situation, in and out, you're rushed. They can really take their time and really support you. I can't speak any more highly of pelvic floor physios or physical therapists, wherever you're located, what they're called. They're a phenomenal resource for managing, clitoral adhesions, phimosis, but really anything kind of genital pelvic, they can really support with a lot of that. So they're absolutely a great resource. And I will link in the show notes a couple directories, both global directories and Canadian-based directories, to find a pelvic floor physiotherapist. You can always use Google, but sometimes the directories can be nice as well to find somebody near you. So thank you so much again for joining us. This was a really great conversation. I'm so glad you were able to make it and educate us on this topic today.
Thank you for having me. It's been fun.
Of course, my pleasure. All right, everyone. Thank you so much for watching. We'll catch you in our next video.